Thanks, John. So I think the last talk I did talk some about when we were talking to patients about their opioid medications, and this is a related talk, just keeping us up to date on what's going on with pain treatment as well as opioids. So this is an article review. I don't have any disclosures. And this was published recently in JAMA, the effects of opioid versus non-opioid medication on pain-related function in patients with chronic back pain or hip or knee osteoarthritis. And they call it the SPACE randomized clinical trial. So I'm just going to review this, a really well done study, and I think it has the potential to affect practice. So the background here, long-term opioid therapy, common, but high-quality evidence supporting it is lacking. There has been this rise in opioid use disorder and related complications that really raise questions about the risks of prescribed opioids. Really, there haven't been randomized trials of opioid therapy that report longer-term outcomes, including pain and function or quality of life. And with that in mind, current guidelines really discourage opioid prescribing. But we are left with this question of what is the role, if there is any role, in opioid therapy for chronic pain management. Last time I did talk about sort of the folks who are already on and may have trouble getting off, and I think that's a separate topic. This is really talking about folks who have chronic pain and where should we go with their care. So this is the Strategies for Prescribing Analgesics Comparative Effectiveness Trial. And it's a pragmatic clinical trial of opioids versus non-opioid, two different strategies for treating pain. And when I say pragmatic clinical trial, you're going to be seeing a lot more of these. These are kind of state-of-the-art kinds of trials. Instead of doing a trial of a medication, a single medication at a particular dose, double-blind, placebo-controlled, it really pragmatic trials allow you to look at treatment strategies as groups and see if your treatment strategy is possible. There are a lot of advantages to this. Compared to more defined trials. You can use broader inclusion criteria, they tend to. They're often more flexible around what kind of medication selection or dosage might be provided. In this trial, they did allow even other non-pharmacologic therapies, although the pharmacologic prescribing strategy was what they were experimenting with. And then they really, the outcome assessment, whether people participate in the intervention or not, if they don't find it useful and they drop out, you still count them because you're trying to test a strategy that you're going to apply to a large group of people. So the patients in this trial, they're all VA patients. They were identified by electronic medical record search, looking for the diagnosis of back pain or hip or knee osteoarthritis. And they called them up, did a phone screen. They had to have more than 6 months of chronic pain. They had to have a severity on there's an instrument called the PEG, which is 0 to 10. It's basically a 5 or more. So they had to have pretty significant chronic pain that's lasted a long time, and they've tried some medications for it. In this trial, like I mentioned, this is not about folks on opioid therapy, and they actually excluded those patients who were already on opioid therapy because they were trying to compare opioid therapy to a non-opioid strategy. Of course, they couldn't be in the end of their life, and they did allow people with a history of substance use disorder and or depression or even active depression to be in the trial, but if they had active substance use disorder, they were excluded. So the randomization, this was they stratified it based on back pain versus osteoarthritis. Wanted to see if each of these strategies might be different. There might be different outcome depending on those two groups. And then the way they did it was they did an enrollment visit. They did all the consents and all the pre-measures. And then the randomization was not done at that visit, but was done at a pharmacist visit, the first visit a week after that enrollment. So they kind of did this this is a strategy. You make people do stuff to get into the trial, and you don't randomize them until they've done some showing that they're going to show up. So they did that, and the patients and the physicians were not blinded. It would have been ridiculous to try and blind this because they're using multiple different kinds of medications. And then the outcome assessors were blinded to the group assignment. So how did this intervention go? It was a collaborative care model, basically a pharmacist who worked with every patient in the trial, and they used different strategies depending on how they were assigned randomly. So the pharmacist would review past pain treatments, the patient's functional goals, their preferences for treatment, and any comorbidities that might affect what medication they could take. And then they basically did monthly visits. They were usually by phone, just doing trials of medications. And when they got stable, they would do them less often, but it was basically a monthly intervention, mostly by phone. Both groups used a 3-step medication intervention, again, targeting this PEG score, which is really a measure of how bad is your pain, both in related to intensity and function, and then how they were progressing towards their goals. And they had an opioid intensive strategy versus an opioid avoidance strategy. So the intensive strategy really started with short-acting opioids. You can see a bunch of them listed. They're the standard ones. They could add a long-acting opioid, morphine or oxycodone, and the step 3 was transdermal fentanyl. They titrated the opioids up, any of them but they did have a trial maximum of 100 milligrams of morphine or the equivalent per day. And when they got to 60 milligrams of morphine per day, if they weren't doing so well, they could try a different one. So again, this really is kind of how people did chronic pain management when they were doing opioids. When we were using more opioids, this would be a pretty standard kind of algorithm. You're titrating to response, you're seeing how people do, trying to get the maximum benefit. And then the opioid avoidance strategy, again, this is not rocket science, but it does take some work. So Tylenol or non-steroidals, obviously people who have medical comorbidities that would exclude these might not get them. And then adjuvant medications would be the second step, and that's tricyclic antidepressants, my favorites, nortriptyline, go nortriptyline, and then gabapentin, and then topical capsaicin or lidocaine would be, those would all be step 2 medications. If people tried some and didn't want to do it again, they wouldn't do it. They could mess with doses, but that's step 2 medications. And then step 3 were medicines that at the VA needed some prior authorization, like Lyrica or pregabalin or duloxetine, which is Cymbalta. And then tramadol was also included in step 3. Tramadol works on the opioid receptor, but clearly has it does have less abuse potential than other opioids. So, you could argue it shouldn't be in there, but it's a reasonable choice the way they did it. And then changes, they can titrate the dose, they can replace, they can add medications. That's the opioid avoidance strategy, all delivered by a pharmacist. Okay, so the results. They had 265 patients who went to that enrollment visit, and 25 of them didn't show up for randomization. So, and they had incredible follow-up. They had 90% follow-up at all the time points, probably because of, at least in part because of their methods here. But also, I think, probably because the patients felt they were getting something useful. So even the 12-month follow-up was well over 90% of the patients getting their assessments. The mean age was 58 years. It being the VA, only 13% women, 65% had back pain as their primary. They were randomized within that back pain stratification. The primary outcome was pain-related function over 12 months. So that means they're integrating the results over 3, 6, 9, and 12 months. So getting all those data, and they found no difference in pain-related function between the two groups. They had about 30. They had another measure which was and this is pretty standard in the pain world, a 30% improvement in their score counts as a response. And so they had about 60% of the patients in both groups reported a 30% improvement. So pretty good response. If you look at the data, people got better. Some of that could be due to just going back to the mean, because that people who enter trials often have worse problems. You just follow them and do nothing, they may get a little bit better, but that's a pretty good improvement rate. And then the secondary outcome, the main one, was pain intensity, which I think probably surprising to many was better in the non-opioid group. But this was statistically significant, but they had a 10-point scale, and it was about a half a point difference. And there's been quite a bit of research on what counts as a real clinically important difference, and it really has to be over a point to be clinically important in these kind of trials. They had 30% improvement in 54% of the folks in the non-opioid group versus 41% in the opioid group. That was barely statistically significant. So, and then the other results, these are more secondary outcomes. The opioids had more medication-related side effects or symptoms. There was no difference in adverse outcomes. Opioid misuse, which they did a reasonable job looking for it. It was not really an issue for many patients. Again, these are patients who were not on opioids before the study. And other outcomes, they did a wide range of them. The only one that ended up different was anxiety seemed to be better with the opioid strategy. And that makes some sense. And maybe one of the reasons why people with anxiety and depression end up on opioids longer term, because it does help people's anxiety. And then less than 15% of the opioid patients had a dose even over 50 milligrams. Again, the limit was 100, but very few people got up that high. Tramadol, you can see, there's like 4 follow-up periods, so they could have gotten it at any one of those periods. It was a pretty small percentage of people getting that. And then they looked to see whether the back pain or osteoarthritis group responded differently in some way. So they did an interaction, and they found a non-significant interaction of the diagnosis, back pain versus osteoarthritis, by treatment group on the pain outcome. That analysis, though, it did sort of show a trend. The P was 0.25. It looked, but if you look at the scores, opioids did a little bit better for back pain. Non-opioids did quite a bit better for osteoarthritis. Don't know what that means. And it wasn't anything statistically significant. So the strengths of this trial, this pragmatic design, so it could include a wide range of patients. This was it was done in a bunch of VA clinics, all in the Minneapolis area. So they didn't have to do a huge national trial to get these patients. They were able to find them. Included a lot of patients, flexible treatment, and maybe that's why there was such really high retention in the intervention and the follow-up. They could do a treat-to-target approach, which is really a lot of how we do clinical medicine, and then the structured reassessment by the pharmacist really may be the key to making medications, including non-opioid medications, work better. The weaknesses of this study, you could argue they didn't really push the dose. I think in this day and age that it would be a hard thing to do, and there's so many, really most of the problems we've seen with opioid prescribing do come with the higher dose patients. So I don't think, it is a limitation, but they did allow dosing up to 100 milligrams, and they didn't get there most of the time. The VA population, of course, is mostly male and in that one institution, and they did exclude patients on long-term opioid therapy. They actually did another trial that was pretty similar to this, that included people with or without opioid therapy, and did a kind of a nurse management thing pretty similar to this, and they found that it was effective in both populations. So I don't think this can only be for people who are not on opioids. So I think that's everything I've got. The conclusions. Yeah, among patients with back pain or osteoarthritis, opioids did not result in better function over 12 months. Non-opioids were associated with reduced pain intensity compared to opioids, but this wasn't really clinically significant. And opioids cause more medication and adverse symptoms. So I think this does support the guidelines that discourage opioids for treatment of chronic pain, but I think also really provides kind of a roadmap for how providers and clinics might start to do a better job actually helping people with their chronic pain. So that's all I've got. I got wondering whether anybody can imagine this happening in their clinic. I think I can. We have pharmacists who are kind of into this and might be actually interested. And then I guess I just, when we do Hep C treatment, we have this finite, we do the workup and treat them, and it's not very long, and then we're done. This also has some of that. This was a 12-month trial, but it was monthly, so it's really not all that intensive. So I'm just wondering what people think, whether this changes how they might think about getting their clinic to work with patients in this area.